off. And then one of the most important things is, when are we at neurostability? So it's that area where you get some improvement after a spinal cord injury, and then you sort of stop and plateau, usually around that 6 month. And then we also look out for people who are actually getting worse, which can portend to ongoing neck-related or spinal cord issues. And as I said, every patient's unique. The biggest thing for us is patient goals. It's like, what do you want to do? What are you expecting out of surgery? And, if that lines up, then those people are oftentimes good surgical candidates. We do a full exam, shoulder to fingertips. We're looking for contracture, spasticity. We're moving you, we're having you move. We're grading everything sort of using this scale here, which ranges from just a flicker of function to full strength. And we actually have this sheet where we assign numbers. And again, we're doing examinations usually, hopefully very early after the injury, within a couple weeks. And then we're kind of regrading it at the first visit in clinic, and then repeating that every, sort of six weeks to 3 months as needed. Sometimes other imaging studies are needed, x-rays if there's ongoing shoulder issues, x-rays of the neck, MRI of the neck if there's ongoing neck-related issues. We use a lot of what's called EMG, or electric diagnostic testing. This is a way to check, for on early recovery in the muscles that may be seen only on testing but not on examination. We supplement this with other testing I'll talk about in a second. And again, the therapists are critical. Addressing contracture, restoring motion, strengthening muscles that we're thinking about using for surgery, giving people home exercise programs, and getting them fitted with splints. And as I said, we sort of repeat this as needed until we get to stability, and then we develop our surgical plan. So I'm going to talk, there's two major types of surgery that we do. One is tendon transfers. So we take the tendons of muscles that are functioning and expendable. So if you have three tendons that flex your wrists, if all three are working, we can use one to do something else. And then the other is nerve transfer, which we'll talk about later. So tendon transfers are what's been done for a long time. The pros for them, you can do them anytime after injury. There's not like a clock where time runs out and you're no longer a candidate. And because we've been doing them for so long, the outcomes afterwards are very predictable. There's still a learning curve to doing them. You can either set them too loosely, where it doesn't pull enough to do what we want. If you do too much too soon afterwards, you can have failure, or the tendons will sort of pull apart. And they do require 10 to 12 weeks of therapy and splinting afterwards. So sometimes this can be a big ask for people, especially where you can end up in a splint from your upper arm down to your fingertips, early on. And so people oftentimes who have been living with spinal cord injury, you need to plan ahead. How are you going to adapt your routine? Who's going to be available to help? And so it is a big sort of buy-in ahead of time. So I talked our three goals that we're looking for are elbow extension, hand open, and hand close. And I had some great gory photographs that Dr. Wilson wouldn't let me show. So we're stuck with these little diagrams instead. And so for elbow extension, the way we do it most often, so you have two, like I said, you have sort of duplicate function. You have two muscles that flex your elbow. We take the biceps, which is the big one that everyone knows about in the front, and we move that to the triceps in the back, and we leave a nice big elbow flexor so you don't lose you might lose a little bit of strength, but most people don't notice it. Give you the ability to extend your elbow, and I'll show a video demonstrating this. Other groups in Europe use part of the deltoid. We don't like this as much. It requires taking either a piece of cadaver graft or graft from your leg, putting that in, and then putting that in. And they probably work about the same, to be perfectly honest. So then when it comes to grasp, there is a grading system that I didn't put in here because it's just a lot of charts. And so what it is as your spinal cord injury moves down, different muscles then become available for use for tendon transfers. And so we use that to sort of guide how we do what we do. And so most people fall into what we're calling grade 1 or grade 2. So ideally, people can extend their wrist on their own. We then tie in some tendons on the back. So as you just let gravity drop your hand, your fingers will open up. You pull your wrist back, and then we use one of the elbow flexors to restore the ability to pinch. And so giving people about 5 pounds of pinch really helps with writing, self-catheterization, and other activities. And then as the injury level moves lower and lower, we have more muscles available. So this is a patient. It's actually interesting. So on her right, this is her right side. I'll show you on the left we did. So she was someone who elected for tendon transfers on the right side, nerve transfers on the left, because they work in different ways and they have different benefits, which we'll talk about later. So this is her right side. So she had a biceps to triceps transfer for elbow extension. So you can see she's dropping her hand for that opening. She can get something in between that thumb and that index finger. And then now she has the ability to pinch with it. And then we've given her the ability to extend her elbow. And so it's important to note, this isn't what I call a normal or neurotypical arm, but it's a functional restoration for her. So now we're going to talk a little bit about nerve transfers. They're different. There are some benefits compared to tendon transfers, but there's also some drawbacks. And so the pros to nerve transfer, this is essentially just like rewiring your body. In the same way, we're taking nerves that are going to extra muscles and then moving those into muscles that we want to have control over. And the nice thing about a nerve transfer is instead of having to retrain these muscles, it just is if you think it, your body then does it. They're probably not as strong as tendon transfers, but they're better for fine motor. There's better dexterity. And you can sometimes restore function to multiple muscles using a single nerve as opposed to tendon transfers. The other thing that's nice is after surgery, these people just go into a sling. There's really no immediate early rehab. Blake starts working with people once we see the muscles start to work. The downside is, as opposed to tendon transfers, which you're often running in 2.5 months, these take up to a year or a year and a half to really start working. And so it requires some patience. Also, as opposed to, so tendon transfers can be done anytime. These in a certain set of the population need to be done within the first year of injury. There's also a small subset of patients who can be done later, but that's not everybody. And that's related to this. And so when you have a spinal cord injury, there is a discrete zone of injury. And so any nerves coming off of that within that zone of injury, and that varies by person. Some people have a very narrow zone, some people have a very wide zone. And so any nerves that are coming off in that zone have to be done within a year versus if you have a very narrow zone, any nerves that are below that can be done anytime, doesn't matter. And we have a way in clinic of kind of looking what this looks like. Again, no gory photographs, just drawings. What we do, we see me afterwards. Yeah. So for elbow extension, again, the goals are the same. Elbow extension, hand open, hand closed. So for elbow extension, we're taking one of the little rotator cuff nerves and putting that into the triceps. Sounds easy. Takes about an hour and a half. For finger flexion, there's multiple different nerves that people have used. The lowest one is the one we like the best. It's one of the wrist extensors. This gives you the ability to flex your fingers and pinch. The other ones, this is all relatively-ish new within the last 5 to 10 years. So people are still sort of figuring this stuff out and what is the best combination of things to do for patients. With our group, I think this wrist extensor has done the best. And then for hand opening, we're moving a nerve on the back of the forearm that typically turns your hand up to the sky, and that gives people the ability to open their hand afterwards. This is probably the most commonly done one and probably has the best outcomes afterwards. So I'm going to show a case of this. This is our first patient, 30-year-old, so motor incomplete, 7 months after injury. He had no triceps, no finger, no wrist, and he had a centralized wrist. And so we're going to move 3 nerves around for him. This is him before surgery. So you can see he has wrist extension. He can turn his arm up. This is him trying to open and close his hand. Nothing's happening. And then he's using his wrist extensors to lock out his elbow to extend it. So he's cheating a little bit, but if you break it, put him against gravity, he's still trying to cheat with his wrist extension, but he can't. And here he is 18 months after we're getting ready to do his other side, same surgery. And so we've given him his elbow extension back. And the nerve transfers, they're still sort of tenodesis assisted, but we've given him the ability to then, sort of open his fingers and pinch. His thumb's getting caught into his palm, so we still would want, I've encouraged him to, we can fix that quite easily. He's happy, he won't let me. So, and I can't force him to. And so that's just showing between his two sides. And again, so this isn't, normal, quote unquote, but this is for him functional. And so the nice thing about nerve transfers is you go home the same day, you're in a sling, you resume sort of everything afterwards. We just tell people don't put pressure over the transfer sites until we tell you. And so where we are now is probably a combination of these. We found that that works best because nerve transfers are better at some things and tendon transfers are better at others. And so we either do it one of two ways. We either plan and say, all right, first stage is nerve transfers. And when those start to work a year later, then we'll do your tendon transfers. Or the unplanned combo, which is we're going to do just nerve. One of it doesn't work. We have our backup plan for tendon transfers. And then we also do balancing. So like that patient I just showed with the thumb getting caught in the hand, he's someone who then we come back and say, look, we can fix this. It's just a touch up at that point. So this is this was the first tendon transfer I showed. So she had nerve transfers to open her hand, which you can see here. But this really isn't functional because she's kind of in this claw type position. So what we're going to do is make her fingers so they're kind of stuck down. So when she opens, she's not clawing like this. And then we're also going to do tendon transfers to give her pinch. So this is a planned two-stage surgery. And so here she is after that second surgery. And you can see the difference between the tendon transfers, which don't open as well, and this, which opens better. And so she uses her hands for different things. So she uses hand to grab bigger objects, using her other hand for writing and things like that. This is sort of one of our she had nerve transfers on both sides. So we've got great elbow extension on both sides. The hand opening on her left and the hand closed did really well. But on the left side, the nerve that we moved, I'm sorry, on her right, the nerve that we moved for pinch didn't work out. So she's someone who will have tendon transfers done at a later date to fix that. And again, she's one of these people that thumb is getting stuck in there. And oftentimes we get them into splints, again, sort of to fix that clawing or that unwanted hand opening. And we can build this splint internally, or she can just wear this splint, which she's comfortable doing. And then this is showing her other side. So we got good open, but the close didn't work as well. And so now we're going to do a secondary tendon transfer just to give her that pinch. And so that's my kid. So, the clinic is a great place. We love seeing our patients there, coming up with these plans. I think we spend a lot of time looking at what are the patient's goals, how are we going to get there, what's plan B if it doesn't work. The main tenet is don't do anything to make anybody worse. And even a little bit of functional improvement can mean a lot to people with tetraplegia. So thank you. After Blake talks, if you guys have any questions.
Yes.
Yeah.
After you do a tendon transfer, do you lose a touch sensation?
So touch and sensation is would be the holy grail. So all these nerve transfers and tendon transfers is just motor function. It's not sensation. And so if you're lacking sensation, people still need to look at their hands to see, if and what they're grabbing and touching. But yeah. I'll let Blake go and then
We'll save a little bit of time at the end for for questions. All right, my name is Blake Perkins. I'm a physical therapist and assistive technology professional at MetroHealth in our PM&R department. I do a whole bunch of stuff in spinal cord injury. If you don't know me, I kind of work in technical management clinic. I work in research in spinal cord injury. I also run our assistive technology program, which consists of our complex wheelchair and seating clinic, in addition to what I'll talk about today, which is the Adaptive Life Technologies Lab. And I think if you're looking for kind of a big theme, a big takeaway with this between what Dr. Chepla spoke about and what I'm going to talk about, it's that we're trying to take what's spared from an injury, whatever that access point is, whatever that function is, and then expand it to as much functional utility as we possibly can. And do that in a way that's meaningful and important to the person. So that's what kind of the big takeaways between these clinics are and how everything sort of marries together. So I'm going to talk fast because I have entirely too many slides. And also, if you get bored, I have pictures of my daughter as she grows up. So this is a long spiel about the alt lab. I'm not going to read all of this, but it's the big takeaways that differentiates the alt lab from other assistive technology programs, frankly, within the country, is that we involve people with lived experience, multiple people with lived experience. I'm a clinician. I had a spinal cord injury. We involve 2 other consultants who have high-level cervical level spinal cord injury, one of whom owns his own IT business and helps us pair together these technologies, which are frankly sort of novel in the pairings that we put together to meet these needs for people. That separates us in a big way. Another big separator for us is that we really dig into community collaboration. This is a team. When you come in to see us in the alt lab, it's also a team in how we try to pair people with resources to get things funded, to get things installed, and to follow along as a part of your life as a person living with a spinal cord injury. Though the alt lab is not limited to people with spinal cord injuries. That's kind of what I'll focus on today. I'm just boshing around. All right, go next. Okay, so this is my daughter when she was born. What is adaptive? It is adaptive or assisted technology exposure not limited by traditional funding sources. That is critical. Oftentimes when people come through traditional course of rehab, your exposure to technology is limited to what we know there are reliable funding pathways for. That's not fair to you. It's not fair to me as a person that lives with a disability. Our goal is to expose you to as many things that may or may not be considered durable medical equipment that might meet really important needs for you. So that's one of the big things for us. Clinician guided. I'm the clinician. I'm not the only clinician. We have other people that we bounce ideas off of. I work with people like Megan and Lexi who are here and Darcy to try to put our heads together and solve problems for folks. Oftentimes we've got to get creative when we do that. And it helps to have multiple skill sets and multiple brains working on a problem to solve for people. Credentialed assistive technology expertise. I mentioned that. Lived experience and community collaboration is also a big part of it that I've already discussed. For the next one. Why is it important? You don't know what you don't know. Limited tech exposure in traditional rehab. Already mentioned that, but essentially when you get out of traditional rehab, you hit that plateau, you go back home and you're literally and figuratively left to your own devices to figure out what devices help you. We try to expose you to stuff that not only we know works, has been shown to reliably work for multiple populations, but we let you try it in clinic. So it's a try before either buy or use alternative funding pathways to get this stuff paid for. So that's a big part of it. And ultimately, we're trying to avoid wasted resources. Your money, the Medicaid waiver funds, workman's comp funds, voc rehab funds. We're trying to save time. We're trying to save resources and try to pair people with things that are critically impactful to their function, return to work, return to vocation, whatever it is. Next one, please. Service gap. So as far as the assistive technology programs go to serve people of all ages, though we really focus more on adults, we're in sort of no man's land prior to the establishment of the alt lab. So you've got excellent resources at Ohio State University and at University of Pittsburgh Medical Center. We don't have much up here. There's Children's Hospital, which is fantastic. There's UCP, which is fantastic. That's Children's and that's UCP. Folks with spinal cord injury and other disabilities that don't sort of fit into those umbrellas are kind of left to figure it out for themselves. So who's involved? This is a team of lived experience folks that I've talked about. So that's me in the middle. Over here, this is Steve Polakowski. He runs his own IT business, started a nonprofit as well that serves people with spinal cord injury. This is Jacob Schuler over here. He recently came on as a consultant in the alt lab who helps pair people with resources throughout the community that might help get this stuff paid for, provide peer support. He's also involved in some research studies as a part of our research team. So that's our group. You can go to the next one. Jacob, already kind of mentioned him, but he's a Practice Persons with Lived Experience Program Fellow, founder of Learn Spinal Cord Injury, offering lived experience, research, and insights. He's a facilitator at Augmental Tech, which is the manufacturer of the mouth pad, which is essentially a retainer that has a mouse and control interface for people to access the computer, control power wheelchairs, control their cell phone for people that don't have upper extremity function and dexterity to do so. Community reintegration, that's sort of his ballpark. And Jacob has done a really nice job with sort of helping people navigate those pathways. Next one. This is me. I don't know if I've told, a lot of you folks probably know this. I was injured 13 years ago as part of a motorcycle accident. I am a T10 Asia A, well, let's see, T6 Asia B. At paraplegia is the level of my injury. I have a daughter here. That's my wife. I'm a has-been musician. I don't have time for music anymore, and I'm a assistive technology obsessed physical therapist. I'm not a traditional physical therapist. I'm a weirdo. And if you ask any other PT, they will totally agree with you. Good, then I can help you out. So that's me. Go to the next one. This is Steve. Steve is a wizard, frankly, when it comes to information technology. He is ATech at Active Technologies president. That's an assistive technology nonprofit. He's an IT business owner. 26 years technology experience. He owned his own IT business, I think, roughly 20 years pre-injury, and has done so 6 years post-injury. He is a guy that if we could copy and paste him, the world would probably be a better place. He's an incredible guy. Looks a lot like Vin Diesel. I like to pick on him about it. And he is 8 years post-SCI. Go to the next one. Who else is involved? We collaborate with our PM&R department, as already alluded to, Case Western Reserve University, physicians, therapy clinicians, social workers, research investigators, and administrative staff. We partner with the Cleveland State University Spinal Cord Injury Volunteer Corps to help with the installation and configuration of some of this stuff. We also have recently established a collaboration, not a partnership, with the Cuyahoga County Board of Developmental Disabilities. And this is important to note because if you have or are a part of a Medicaid waiver program, you have access to those funds, the service administrators are there. So we need to have good relationships and open discussions with them to make sure that we can sort of lay out what we're asking for and why they should pay what we're asking them to pay for as it pertains to assistive technology. Next one. How does it work? Visit one, evaluation. Oftentimes I do this virtually because, as we all know, getting around can be tough whenever you have a spinal cord injury and mobility limitations. The second visit, it will be in person with me, and then Steve and Jake will be there virtually to help with trial of these targeted assistive technologies. So on that first visit, we sort of go through an inventory, prioritize tasks that we can address with provision of the different types of technologies. You come in for the second visit, and we actually try it if we have it in clinic. And we were fortunate enough, we received a grant to start this, that we have a good inventory of technologies for people to try. You try it in that second visit, we identify, okay, this is really going to work well for this task that we identified is really, really important to you. And then we go through the process of getting it funded. That involves me writing up a letter of medical necessity, a letter of justification, partnering with your caseworkers, your service administrators, and sending that to them, detailing why we need to get paid for it. And then beyond, follow up and follow along, cooperation with the credentialed vendors, community members. That kind of goes into the Spinal Cord Injury Volunteer Corps, who we can partner with to have some of this stuff installed and configured in your home. Next. Outcomes. If you're into this sort of thing, you might not be, but we use evidence-based outcomes with reliable psychometrics. This isn't just we're throwing spaghetti at the wall to see if it sticks. We're actually going through the process of identifying tech. You're rating your performance and your satisfaction with that performance of whatever that task is. It's actually sort of a version of the Canadian Occupational Performance Measure, which Dr. Chepla alluded to in his slideshow. And we get that at baseline, and then we get it after you get your technology. And we hope that we've made a difference in a positive direction for you. Go on. Funding. Already talked about this and what we're doing about time. So I'll go into it. Yeah, so Medicaid waiver programs, they will consider coverage. Medicaid waiver programs consider coverage for things that are not going to be paid for by insurance. So that's important to note. A lot of times that's a brick wall, because if you tell a vendor, let's say your wheelchair vendor, I really want to pursue this device, it's not coded. They don't know what to do with it. But if you go through a different avenue of going straight to that caseworker with the device that's not coded and painting the picture as to how it's going to help you as a person living with this disability, we've gotten those things reliably funded, which was a massive home run when we first started doing this. I didn't know if it would work out, but a lot of folks that are on these waiver programs have $5,000, $10,000 pools of money that can be utilized every year. Oftentimes they don't get utilized because people don't know where to spend them, and service administrators don't know how to spend them impactfully. So we try to be as good as we can at helping you spend money. BWC, Cinemis, and all this, of course, is case manager dependent. If you've got a really, really good case manager, it's open-minded and really looking out for you as an individual who they are serving, these things go much smoother. But of course, there's interpersonal relationship variability, and sometimes difficulty arises with that. But if there's a fight to be had, then that's my job, is to initiate that fight and be a pain in their butt until they say absolutely not. And we haven't had an absolutely not yet. So we're fortunate with that. Philanthropic organizations. We have been in a loop with the Ryan Shazier Fund. If you're not familiar with them, it's worth being familiar with them. They grant up to $15,000 one time to people who have had spinal cord injuries. They have a 2-year gap. It's called the golden window, I believe, where they like to serve people within 2 years of their injury, but it's not limited to that. So if you've been injured for 20 years, they'll still consider you if you can, lay out an impact statement of how this sort of technology is going to be really important to you. I can actually apply to that on your behalf and help you craft that application to give you the best opportunity to get these things paid for. And all that offers us a venue for me to do that. Self-pay. Obviously, at the end of the day, if you don't have any access to these other funding pathways and you're spending your own money, you want to spend your money wisely. And we believe that we offer some value from that perspective and allowing you to try before you buy as much as we possibly can. Barriers. We love barriers. Managed care, gaps in case manager education and or awareness, and the mysterious policy. And I removed it says see next slide. I took that off because it's this big Ohio code that is boring as all get out. But really what it boils down to is disappointingly enough, there are a lot of case managers who aren't aware of the legal statutes that the services they provide are subject to. And so I have to, and you as a part of the team that's trying to get this stuff approved, have to educate them as it pertains to that. So look, you've got these pools of money if you're a part of this waiver, right? And if you've got this waiver, you've got these pools of money. And this is how this technology fits into this pool of money. And now I'm going to tell you why you should pay for it. And we work together to kind of help educate them. And we have to do it in a cooperative way that's not combative. That's where you start to get those brick walls whenever you start to attack people and say, why are you not going to pay for this? How could you ever think about not paying for this? And then letting the emotions start to take over. If we take it in a really sort of pragmatic approach and lay out why it's important and why this sort of pool of money is appropriate to pull from, things tend to get a lot better. Technologies. So this is alt lab. This was a while back. I have way more junk in there now. It's a room in our MetroHealth Center for Rehabilitation Research that is getting smaller every day because we keep piling more stuff in there, which is fun. It's more stuff for us to play with, but yeah, this is the alt lab. You can go to the next slide and I'll kind of go into some of this stuff. So we had this fancy photo shoot that we all were cracking up in between photos, but we had some good stuff come out. And this is just kind of lays out some of the technologies that you might be able to try in the alt lab. So this is a grasping device. It's called Hominid X. This is the Monevo Drive head controlled power wheelchair interface. So you can use head control, calibrated head movements to drive your power wheelchair, to access environmental controls in your home, to access the computer, to call people, to call emergency services. It's a German company, and I've gotten a few of those approved actually through insurance, traditional insurance, which has been really encouraging. This is a Freedom Tracks. So you all have probably seen those big tank-looking tracks that go through sand and snow and picket and everything else. This is a detachable, similar device called Freedom Tracks that manual wheelchair users can roll up on, secure their manual wheelchair, and then there's a joystick that mounts to it, and it does the same thing, but it weighs 150 pounds and costs $6,000 instead of whatever, 40,000, I think is what some of those other models cost. We've gotten one of those paid for successfully through Workman's Comp, and I'm working on another one through Medicaid waiver. This is a Samba robotic toothbrush. You've probably seen these. I think I read about one actually in New Motions magazine, United Spinal magazine, where it's a button that you can actually hit. People with impaired upper extremity function can hit, And then it's a robotic toothbrush that will actually clean both sides of your mouth, top and bottom. This is a power toothpaste dispenser. So between the two, we mount the power toothpaste dispenser on the wall. You can roll up to it. You can put the toothbrush in it, squirts out toothpaste on it. Does the same thing to the other side, push the button, and the button is such, it's large enough that people can actually use some of the bony prominences in their hand to turn it on, turn it off. And then you're independently brushing your teeth, which is a big deal if you've always been reliant on caregivers to brush your teeth. If you haven't, have your loved one, have a friend try to brush your teeth. You'll get poked in the mouth and throat more times than you care to admit. So that's that. You can go to the next slide. A part of the alt lab. So the alt lab is, I mentioned that it's technologies that are not traditionally covered by insurance, but it does complement what we do in our outpatient complex wheelchair clinic. So when you come into the alt lab, I'm not just going to ask about all these tasks that involve environmental control, computer access, so on and so forth. I'm going to ask about your chair. I want to get some outcomes about your chair. I want to see if we have any immediate gaps we need to address with that, because that's sort of the foundation and the substrate for everything else that we do. If we don't get your chair right, we don't get your seating system right, this other stuff goes to the back burner. We make sure that your chair is in good situation, that you're in a good situation from that perspective, the skin's in a good situation, and we address that first. Once that's in good shape, then we'll kind of branch out to some of these other functions that we're talking about. You go next. And, these are cushions and different types of immersion cushions I won't get into. You can go to the next one. Same thing with backrests. You go to the next one. Pressure mapping. If you do have skin breakdown, we have a pressure mapping system that we can actually take a nice picture of your butt and see where you might have some hot spots that need to be addressed with seating. We do custom seating molds when we partner with vendors and make sure that we can address that for you, not only today, but set you up for success long term. We want to make sure that skin's in good shape, posture's as good as it can possibly be today, and then set you up for success for the next several years. As you know, it is a 5-year marriage a lot of times, but we don't like to approach this as a see in 5-year situation. There's a follow-up and follow-along process that the evidence lays out we need to instill when we're serving these patients, serving you guys, and we put that into practice. So I want you to reach out to me if things come up along the way, so we can get you back into clinic. We can revisit things. Things change. Our bodies are dynamic. We age with spinal cord injury, and we want to address those sooner than later. I don't like seeing people 5 years, 6 years down the road, and then now they have a stage 4 pressure ulcer that we're trying to heal that could have been addressed before if we had more open communication and there was more of that follow up and follow along. You go next one. This is some new smart technology. So this is a smart air immersion cushion, which is really, really cool. It actually is similar to the alternating pressure mattress that you might be familiar with that you sleep on. This is a company called Caligon. I don't know how you say it, but it changes the pressure in different air chambers in the cushion throughout the day to sort of augment and supplement pressure relief that you have to do, that I need to do right now, actually. And then this is a booster. You've never seen one of these. It's real cool. Here at MetroHealth, we are a Roho factory. We love Rohos. I love Rohos too, but there's one big problem. When they pop, they do nothing at all good for anybody. You're sitting on either your metal seat fan or seat sling. This booster will protect you from that. So it has a clinician mode where I can set what that pressure needs to be in your cushion. This is done in clinic. And then we set that on the Caligon. That valve hooks to the valve of your Roho, and we tuck it under your chair. It usually hooks up on mount, however we need to. It's a battery charged device. And then if it detects an increase or decrease in air pressure from that calibrated number, whatever their units are, that's not millimeters of mercury, whatever that calibrated amount is, it will add or release air pressure to maintain that. So your air pressure changes if climate changes, you go flying on an airplane, it changes. There's a lot of factors that impact that. And really, I'm trying to figure out a way to protect people from the dangers of Rohos when Rohos go bad. This is a really good device for that. We've gotten those approved through insurance. So that's very encouraging. Go next one. And this is Tolt iDrive. Go next one. More technology, adaptive video games, adaptive grooming devices. This is a freewheel. This is some home modification stuff. I should mention this before I go any further, that we are a credentialed rehab technology provider through vocational rehab. So if you're at work hoping to get back to work and you work with your counselor, they can put an authorization in for the alt lab, and we can go out to your home, go out to your workplace, evaluate you, assess your environment, and then actually get that technology paid for through vocational rehab, which is very encouraging. Go to the next one. This is home access, home security stuff. A lot of this stuff is pretty ubiquitous, even to able-bodied individuals. But for people who have disabilities, knowing who to exit your front door, knowing that your front door is locked, having sensors, being able to use your voice to control these things is functionally enabling in a lot of ways. Go to the next one. Steppable. This is free software where people who don't have a extremity function to access a computer can use whatever function that they do have, whether it's blinking, whether it's moving your head, opening your mouth, blowing a kiss, to turn into different computer switch points and access points to control your computer, and it's free. We just partner with them. I'm super excited about it. Free stuff is good, especially when it works. Acceptable one. Go next one. Too much stuff to digest? Absolutely it is. Just like my daughter and her stuffed animal from that collection. So the next one, QR code. Scan that if you want. That'll give you a tech register for everything that we have in the whole lab. Thank you. We got about 5 minutes for questions. Anything at all?
Great. Does that booster work with regular rubbers?
Yes, ma'am.
How much is it?
Retails for $400.
Can you go back to the QR code?
And that, by the way, is not the poo-poo rojos. It's just they're when a hole pop, you know, when you get a hole in them or the air isn't what it should be, it does more damage than good. But they are a great cushion when they're right. All right. Any questions? None? Thank you, guys.
Thank you.
We have a break for lunch. I can't.
Excellent.
All right, we go.
I believe it should be, there's box lunches out there, so feel free to help yourself. We have until 12:30 is our next step.